dear colleagues. The morning is, according to general customs, not the time for fairy tales usually, but however, I am now here to give you a fairy tale. And even the scientists among us here have to accept that. And to accept my humble naivety that I'm going to display in the next 20 minutes. The trigger for my presentation here was a letter I received from Dr. Hendricks. He wrote me that he has read this editorial, which I have published in the European Journal of Anesthesiologists, where I spoke about my dreams and my wishes how to develop delivery of anesthetics in future. And this is actually a fairy tale because it's not very scientific, but it reflects the wish of a clinician, of a user of anesthetic drugs and machines. Holistic. Holistic means all-encompassing, and this is what I want to give you as a main message. We should not focus only on certain anesthetics or even differentiate too much between IV anesthetics and volatiles. Actually, they are all parts of the anesthesia and many more drugs which we are using every day. And I would like to see a system where we can incorporate them all into a delivery system. This is what I'm going to speak about. So, the problem is that we all give our anesthetics, our opioids, hypnotics, and volatiles, in the case, for example, of a balanced anesthesia, according to principles and rules which are not actually very scientific and not reliable. There are people who give much opioids and less volatiles, others give more of the volatiles. And why do we do this so differently? Now, the angry girl says it. As a matter of fact, dosing and combination of an anesthetic is not really based on the individual need of that patient who is lying there on the table. What we do is, according to local traditions, availability of resources. In some hospitals, they don't have this agent or that agent because of cost reasons, for example. Then the experience which we made with previous anesthesias, we just transpose them to the next patient without knowing what he really needs personally. Then there is, of course, intuition, the gut feeling, which we develop all of us after a while. And probably this is the most important of all these reasons. Trial and error. And we all overdose a little bit by experience, because giving a little bit too small anesthesia, that can be a catastrophe. But a little bit more, you just pay with time. It will be a longer duration of waking up. So there is not a clear quantitative consideration or even knowledge of the interactions between the involved agents and what is the ideal combination in that individual anesthesia. So what we need is this brain, maybe in a computer, who gives us some kind of a navigation what to give to the patient at the end. So we know actually a lot of things are already available since a decade or even more to do it better. We know the pharmacokinetic properties of most agents in women, in children, in whatever. It's not yet complete, but we are completing it day by day. We have helpful instruments, just like this slide rule, or even better, you can use a computer simulation software like TIVA Trainer, which I love very much because it also displays the interaction of the opioid, if you give an opioid, and then you see where your propofol concentration, where it is in this ideal zone and where is it out of it, when the patient is going to be 50% probability of waking up, and so on. And it displays also the running perfusion pump, how much is delivered at that specific time. So this is illustrating already. This is some kind of a navigation. You can have it also for volatiles, for example, this Gasman software, however, that doesn't display the interactions with opioids. And what is probably at the moment, what as far as I know the best, is the Smart Pilot view, which is already marketed and which gives a quite comprehensive view where we are. Please look at this part of the picture, this PKPD matrix, which I am going to emphasize further. That is the important key of what we are doing. So, going out from my plea, I want to show you the figure there. This is the way how I imagined that it should be such a holistic anesthesia delivery system. So, We have automated IV drug delivery units, these perfuser pumps. They have even integrated programs and protocols for TCI or non-TCI, whatever. The problem is that they are little brains separately which are working independently of each other, and that's not the way. What we need are slaves which are doing what a central brain, this computer here, is telling them to do. We have volatile agent administration, and we even can measure what we give, and we have the ability to compute, but we have to put this all together. We should be able also to insert the manual drug administrations into the computer. So what we still miss is the inclusion of all available drugs in anesthesia in one holistic system, that the computing is also covering the synergies and the interaction between these drugs. It should also be able to display the biological response to the surgery, to the stimuli, and whether it is covered by our anesthesia or not by various means like bispectral index and noxious stimulus response index and so on. And if possible, even with a separate tract for neuromuscular blockade. But what I would emphasize as a very important thing is the two-directional steering. What do I mean with this? One thing is just to display what happens by using certain pumps and putting certain settings. So we make here some changes, and it is displaying what is the result on the PKPD diagram. But what I would like is the opposite way. I want to steer my anesthesia from this diagram. I want to press the button into the surface where I want to have how much analgesia, how much hypnosis, and then all the effectors are steered by the computer. That would be, in my opinion, the future. But, and often comes then the question, do you need a closed loop feedback control? No, actually not. What I still want, I want to be there inside because of the biological variability and because of other reasons. So I still want to make the decisions where to go, but all these other tools are helpful for me to navigate. So this is my rather primitive display how I would like to have it, and actually it has been already implemented quite far in the pilot, smart pilot view. On the left hand, the courses of the drug deliveries, and on the right hand, this matrix with the PKPD display. So we have these things already, just only partially, and as I mentioned in the Smart Pilot, it is the farthest, to the farthest level it is already realized, but not yet complete. And you see in this left side is this matrix, which I consider so important. So how can we go to that matrix, how to understand it? If we accept the conventional view that anesthesia is a combination with analgesia and hypnosis, we take these two important ones, and we can see hypnosis, we can have different levels from awake to very deep anesthesia. With analgesia, we can have from no analgesia to profound analgesia, and just combine them in one graph. And here we have now all situations between awareness, a patient who might be unconscious but has no analgesia, or here he might be awake but has no hypnosis, and of course the deep anesthesia. Somewhere here we make our surgeries. And we also have a limitation where is sufficient spontaneous ventilation, where it goes away into asphyxia. Probably we will find areas where typical kinds of anesthesia we can locate, and then we can tailor much better the anesthesia which we make. Now, of course, navigation is very useful if you travel around by car, and it is the same in anesthesia in this matrix. So in the Smart Pilot, this has been already quite nicely realized. What we have to know is that nearly all anesthetics have both characteristics of being hypnotic and analgesic, both. So this is just a random choice. you can look that you can see that sevoflurane is a hypnotic, but had a little bit of analgesic component. You can make a monoanesthesia with sevoflurane, and the opposite way with the opioids. And just you have to separate these qualities and put them into the respective matrix, and then you can locate where your anesthesia is when you know the dose which you have given. You just have to add all hypnotic activities of the different anesthetics and all the analgesics in the other axis of your graph, and then you know where you are. And the question is how to express it. You must find a unit. And I guess a very good unit is equivalence of one of these drugs. For example, for analgesia, remifentanil equivalence, and for the hypnosis, either propofol equivalence or a volatile equivalent, whatever. And this is exactly done in the smart view. And you see that they are additive here. You can calculate a given dose of fentanyl and remifentanil together, and then you will find your position on the analgesia side, while you can do the same with the hypnotic. They add also up, and then you define the position in this graph. As it is done by now, the calculations of these interactions work, but there are also drugs which have both properties, and I guess we have to break them up and to integrate them separately in the calculation, and then it works. And I'm sure this is possible with every drug if you have the data. We can combine synergistic drugs with different pharmacokinetic profiles, and the result is just simply the addition of the two profiles. Or we take one drug with two different pharmacodynamic profiles, with hypnotic and analgesic effect, for example. This remains probably constant over different periods of time. And we can look how would behave if you the system if you just give propofol alone, and in the units which you should express it, it is the propofol equivalent in the sense of effect site concentration, and for analgesics with the same system with remifentanil equivalents. And if you have these two, then you can locate your situation. And this is just for a moment. But a third dimension is the time. Here, for example, volatile. The more you give, the more it is also resembling an analgesia, or ketamine. But what is very important is that we don't yet have suitable and very useful biological response measurements. We might have for hypnotic effect some kind of a sedation score or BIS, which you can, bispectral index, for example, which you can measure in the unconscious patient. But with the analgesia score, that's even more difficult. We don't have it. And the response by respiratory action is only useful in this region with the very low dosing of the two agents. So here we still have a big lack. But if we would have it, then we could display both the drug delivery on this, the Y and the X axis, and on the X2 and Y2 axis we could display the biological effects. And then there appear the two positions, and here you see then the biological diversion of your patient. If the distance is big, then your patient is behaving differently than the average, and you can deduct from here your consequences, how to change your attitude in that specific case. So I come to my conclusions. Drugs with combined hypnotic and analgesic effects have to be incorporated with separate pharmacodynamic but identical pharmacokinetic representation. All hypnotic effects, all, should be cumulated and translated to propofol or volatile equivalents at effect site. All analgesic effects should be cumulated and translated to remifentanil equivalents at the effect site. The system should accept and incorporate all usual administration modalities, not only IV and inhaled way, but everything else, also the premedication which you have given to the patient prior to the anesthesia. It would be preferable to have a display of biological responses, but unfortunately it's not yet available in a reliable way. Closed-loop steering is not important, not yet intended. My plea is that we have already all technical and most scientific prerequisites for the development of such an independent, holistic anesthesia drug delivery system. Unfortunately, such a thing does not yet exist, except some promising but yet incomplete precursors. Even with not complete and perfectly accurate pharmacokinetic data covering all kinds of patients, a preliminary system could be useful. It would be still far better than the erratic drug delivery practiced now by us every day. And such a system in the clinical use could be kept flexible and updatable, thus enabling continuous evolutive development. The central processor combines the hypnotic and analgesic drug delivery by consideration of all involved interactions between hypnotics and analgesics. Anesthesia may be steered on the matrix surface by distinct trajectories instead of dealing with certain drug dosing at the effector side. The user might choose different trajectories to shape ideal emergence from anesthesia if he wants that the patient awakes very fast, or if he wants that he awakes later or doesn't awake but is well analgized, by increasing analgesia while awakening, or the transition from general anesthesia to conscious sedations, and many, many more. Probably if we would have such a system, we would discover so many useful applications in future. Thank you very much for your kind attention.